Hello, and welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hello, everyone, and welcome back to the Surgical Assistant Podcast. I'm John, and with me, as always, is Kelly.
Hello.
Hey, Kelly, how are you?
I'm good, John. How are you doing?
I'm great. I'm doing good.
Good.
So, welcome back to the show. This episode is it's all about something that we constantly see in the OR, but don't always stop and take time to break it down in detail, and that is the ventral and umbilical hernias. So, as we're doing an ongoing series of hernias, and we're going to talk about each one, break them down, go into in depth about some of them, and then we'll have other episodes that talk about other things that are related to hernia repairs, such as mesh and stuff like that. So look out for those. But as surgical first assistants, we're often the ones standing next to the surgeon. We're managing exposure, handling mesh, and protecting the underlying viscera. So to do that safely and efficiently, we need more than a basic definition of a hernia, I think. So we need to really understand where these defects occur, how they form, what's inside them, and how our technique at the field can directly impact reoccurrence, complications, and patient outcomes. In this episode, we're going to focus on the most common abdominal wall hernias you'll encounter away from the groin, specifically umbilical hernias and ventral or incisional hernias. We'll review what defines each type, how they differ, and why risk factors like obesity, prior surgery, pregnancy, and increased abdominal pressure matter to us as surgical assistants. We'll also touch on some diagnostic workups, including imaging like CT scan, and how they actually can change our plan, and then a walkthrough of an operative perspective from opening and lysis of adhesions to fascial closure strategies, mesh selection, and placement. Throughout this episode, Kelly and I will highlight the first assistant's role in how to optimize exposure, protect the bowel, help with accurate defect measurement and mesh sizing, and support attention-free, durable repair. So whether you're new in the role or you've been assisting for years, we just want to tighten up your understanding and the language around these cases. So this episode is for you. Let's get into the ventral and umbilical hernias from the surgical first assistant's point of view. Kelly, do you want to kick us off with what you have on umbilical hernias?
Yeah. So this is going to be interesting, and I love so many things that you said in that opening paragraph, John. Just about things that we need to know, and how we do on this podcast. We want to address the first assistant's role and what we need to be considering for these surgeries. And before I go into, and what I want to start off with is just that the layers of the anatomical layers that we're going to be dealing with in these particular ventral wall hernias with the umbilical and the ventral / incisional, is that knowing where our hernia is of the case that we're doing is going to tell us first and foremost what we're going to need to be considering for our position. So I did want to just briefly mention here that many times when we're dealing with these, we may want to, the patient's going to be supine, and we can talk about this a little bit more later, but typically they're supine, arms out, unless you're doing a robotic, and many times then we tuck the arms. But I really particularly want to address the idea of flexing the patient and how the patient's body may need to be flexed a little bit, especially and particularly for the robotic repair. And let's just put that on the back burner. I just want people to kind of remember, okay, we're going to talk about that later. So going into these cases, that's one thing that you're going to want to consider. But first of all, just some simple, pretty straightforward anatomy on the abdominal wall. We're going to be considering this as right off midline, because we know that the umbilicus is right at the midline, right? A lot of our incisional hernias are near the midline, maybe to the right or left, but right around that midline. So when we're going from superficial to deep, we're going to encounter the skin. So I'm going down in towards I'm going from exterior to interior here. So obviously we have the skin, we have the subq fat, Camper's fascia in the subq fat. And then below that, we get to Scarpa's fascia, the anterior rectus sheath, and then there's the muscle, the posterior rectus sheath, the preperitoneal fat, and then the peritoneum. And once we get obviously through that peritoneum, then we're inside the abdominal cavity there. So we know that those are the layers that we're dealing with. And a lot of our umbilical hernias are congenital. Is that right? Many of
Yep.
the umbilical hernias are congenital. And a lot of people have umbilical hernias and they
Mhm.
don't really cause any problem until they do. You can certainly live with a hernia. You can live and go about your daily life with a hernia with no problems. But when they become a problem, then is when it needs to be addressed. So I would like to talk about from that surgeon's perspective, and when they're seeing patients in the a patient comes in with a hernia, what is going to be that patient's primary complaint? I think
Mhm.
most of the time it's pain.
Yep.
Don't you? Like a pain or a bulge. They notice a
Mhm.
bulge. It could be pain.
Mhm.
It could be constant pain. It could be pain with physical exertion, lifting many times, or
Mhm.
things of that nature will elicit pain in those areas. And so these things are going to bring the patient in. Now, if we're talking about an incisional hernia, then we know that something has happened in the past for an incision to be made, right? So they've had surgery in the
Mhm.
past. And then there are some risk factors that cause, yes. So, and you mentioned some of them
Mhm.
in that opening statement there. So some of our what puts us at risk for hernia.
Yeah, and before we get into that, though, I was just thinking about what you said about the hernias being congenital, umbilical hernias being congenital, and I got kind of muddled in my thinking because, like I was mentioning, or we talking a little bit about before the show, I mentioned it in the first episode on inguinal hernias. What Henri Frouchot had said, "Every man is a bearer of hernias," to paraphrase it, because that whole area there embryologically is a whole complex mess of hernias. You have the testicular deferens fascia, and you have the testicles descending and the kidneys moving up, and embryologically, what's left of we have the medial umbilical ligaments, and that's kind of what's left of the little communication with the allantois or the waist sac that's outside our body that eventually comes
Mhm.
back inside as we develop embryologically from that little bean or whatever it is to an actual fetus. So
Mhm.
in that respect, yes, but I believe 90% of all umbilical hernias are acquired.
Okay. Okay. So I was, yeah, all
But
right.
I could see why they'd be acquired when you see how that umbilical vein comes right out
Yeah.
into the umbilical cord, so that can lead you to, like, when we talk like, when you brought it up in the inguinal hernias and how the processus vaginalis doesn't close down all the way, that's how you get an inguinal hernia. Same thing here, that inguinal ring doesn't close down all the way, then bingo. So I could say, yes, they are mostly congenital because of the anatomy and how the body forms, so
Right. They're right there at the aponeurosis. And yeah, that would be a naturally weakened area. So yeah, that's a good point. So we know that the incisional hernia is in an area that's been weakened by surgery, by an incision, a previous incision. So I want to bring up and mention that when we are doing any kind of surgery on someone and we're creating an incision in the abdominal wall, the primary risk factor for developing a hernia is wound infection. And this is one reason why we are so adamant about protecting that wound and our sterile
Mhm,
technique, et cetera, and really doing our due diligence and trying to prevent a wound infection for our patient. Now,
mhm,
and we can mitigate a wound infection by all kinds of things, the medications that we might use. Again, keeping our field clean and sterile during the procedure, suture choices that we use, closing techniques,
mhm,
dressing choices, all these things come into play when we're talking about preventing a wound infection. Things that we can't control are our patients, their lifestyle
mhm,
choices, their medical conditions, and some of the most common, I mean, anyone listening should know that obesity, smoking,
mhm.
diabetes, a plethora of medical conditions can affect how someone heals.
Yeah, true.
So, but just us knowing that wound infection is the primary risk factor for a future hernia is in and of
Mhm.
itself important for us to know and consider.
Sure, and it's ultimately true. Some patients just have piss poor protoplasm, and they're gonna develop an incisional hernia no matter what,
Mhm.
and that what you brought up is so vitally important. I've worked with surgeons in the past that want you to not handle the mesh all that much, or they will use IOBAN on the patient's belly
Correct. That's
to
right.
keep the
Mhm.
mesh from touching the patient's skin. I try to
Mhm.
do that whenever possible. I don't really wanna set it on a towel, I'd rather set it on, like, the drape. It's something that's not going to collect lint that could lead to an infection later on. But you're exactly right. And all those
Mhm.
metabolic conditions that lead to that are exactly why we're here for hernias anyway.
Mm.
So,
Right.
but I think it's important to talk about that. And as far as umbilical hernias, we know that 2% of all hernias are umbilical hernias, but they're the most common type of hernias in adults. So, and that they
Okay.
occur in females and at a ratio of 3 to 1 to males. And we can go into that in a little bit, why that happens when we get into the causes and stuff. So, yeah. But also, patients that have cirrhosis of the liver or a lot of ascites can develop an inguinal hernia because it's that
Mhm.
constant increased abdominal pressure, and that's one of the
Mhm.
main causes is increased abdominal pressure for umbilical hernias. So,
Right. Right.
yeah.
So when we're talking about, I just, mentioned the patient coming into the office and symptoms that they're
Mhm,
going to exhibit and what's going to cause them to seek a surgeon's care. In the first place, when the surgeon suspects a
mhm.
hernia, then I want you to talk about some of the diagnostic uh, imaging and how that can augment a surgeon's diagnosis of a hernia and what's going on.
Definitely, they can diagnose most of it is the diagnosis machine or the CT scan. They love put the patient in there, especially if they come in through the ER and they have umbilical pain. Usually, I was lifting something and I felt something pop, or I felt a ripping pain, or I
Mhm.
fell, something like that, and now they have a bulge and pain. So they're gonna do a clinical exam. They're gonna palpate the region, see if it's sore, is it red, is there color change of the skin over the umbilicus, because it's very thin there where it attaches to the
Mm.
abdominal wall. Now that it's just an obliterated stalk of the umbilical cord, but they will do that, and typically most of the time you see fat incarcerated in there, or you can see bowel, and that's why these are important because patients come in reporting pain, and it becomes a problem when it's irreducible. Hernias are
Mhm.
fine as long as they're reducible, but when they become irreducible and they have constant pain is one thing, and then that can lead to an incarcerated hernia where you can't reduce it, and then even worse, a strangulated hernia, and
And what
that's
hey,
a
John.
surgical emergency.
Yeah, it
Go ahead.
is, and I wanna get to that in just a second, but tell
Mhm.
us what reducing a hernia involves and what that means to the person that may be listening and not be entirely sure what that means.
Okay, well, we know a hernia is a protrusion of abdominal contents through a weakening in a myofascial layer, and so, like, when they strain really hard, let's say that weakness pops open and omentum can come out and get stuck in that hole, and it can't go back in again. So when you reduce it, is you have the patient relax, and then you can feel how we all should do this preoperatively once our patients are asleep, is wherever the hernia is, see if you can feel the defect in the fascia. And a
Mhm,
lot of times, I know you've done this, I've done
mhm,
this, a lot of our listeners out there have, is you can feel that fascial defect. It feels like a ring, a very
mhm,
distinct ring. And then sometimes you can't feel it because there's tissue poking through it, whether it's omentum or small intestine or both. But yeah, basically just reducing it is having them relax, and then you push down constant pressure. It also depends on how big the hernia is and how much contents are in that. You might have
mhm,
to use 2 hands, you might have to use, like, a folding in technique to get that push it back through into the defect, and then they usually feel relieved. They say, "Oh, the pain is gone," or it's maybe just a little aching feeling. But
mhm,
a lot of us who are techs or who have been assistants for a while, like yourself, or doing these abdominal hernias, when they're reducing them from the inside and pulling the contents out, a lot of times the surgeon will ask you to push down on the
mhm,
umbilicus to provide that constant pressure so it doesn't go back and slide back inside and re-herniate, because these things have been there for a while. They form attachments, so they don't easily reduce, which is
mhm.
why sometimes you don't get a complete reduction. There still could be a bulge there because there's adhesion. It's the omentum. It's going to get stuck to it, and it doesn't always come out. So,
Right. So many
but
times that reducing it manually, so it's basically just a manual pushing out of those
mhm,
contents out of the defect. So many
exactly.
times that's an immediate treatment of causing the pain. Now, the hernia likely still needs to be surgically repaired
Right.
because it's going to continue to be at least a risk
Hmm.
of a problem happening there. So, yeah, I just thanks
Yeah.
for explaining that. I just wanted
Sure.
our listeners that may not know.
And
So that's just
if you can't reduce it, they usually get a CT scan to see how bad it is, and that can tell them if there's any compromise to that tissue. But if they can't reduce it, but it's still painful, but it's not strangulated yet, they may just do the patient the next day, add them on the
mhm,
next day. If it's been strangulated for any amount of time, which means it's been really painful, you see skin color changes over the incision, pain's been increasing, They say, "It's been like this for a couple of days now, it's just getting worse and I can't stand it." Well, and they'll
Mhm.
send them to the CT scan. A lot of times you'll see it is strangulated, and then
Right.
that's a surgical emergency. They have to go to the operating
Right.
room now.
So
So,
in that respect, we can tell how urgently we need to move and how urgently we need to act
yep.
and getting it uh, attention to it for sure. So I had an interesting experience recently where it was outside of regular operating hours, and we had a ventral hernia added to the schedule that
Mhm.
was again after hours. And the surgeon tells me that this patient has had this ventral hernia for 20 years, and but all of a sudden today he's been having pain the past few days, and then in the past couple of days has ceased to be able to have a bowel movement or
Mm.
pass gas or anything like that. So some nausea, but not really any vomiting or anything like that. So the pain and everything, and with those other symptoms was enough. And I think he did get the imaging and could
Mhm.
see that there were loops of bowel in the
Mm.
hernia. So we have to take this patient to surgery, of course. Now this
Mhm.
gentleman is almost very close to 500 pounds.
Oh god. Yeah.
And we do go to a robotic repair. Anybody listening can imagine. We've all been there, and you're just it's a difficult situation when you're dealing with this body habitus and very high BMI in a patient that's likely undiagnosed with diabetes. He just
Mhm.
hasn't taken very good care of himself, or for whatever reason hasn't gone to doctors and had his he doesn't have his health really in check. So we're fixing this. We get in there, and there's a lot of contents through
Mhm.
this hernia. There's a lot of abdominal contents, fat,
Mhm.
omentum, colon and small bowel was up in there. And it was, in fact, just like you mentioned, it was
Mhm.
scarred. There was scarred, there were
Mhm.
adhesions tethering those abdominal contents in through that hernia. So it was a long surgery, and my point is, and I'm getting to one point of the surgeon saying when I like to ask questions and
Mhm.
pick the surgeon's brain, and this is one of our younger surgeons. He's only been practiced a couple of years, 2 to 3 years. So I like to pick his brain, and he's very
Mhm.
forthcoming in
Mhm.
information. I just enjoy working with him. But he made the statement. He said, "We're not here to for hernia surgery."
Oh
He
my.
said, "We're not here for hernia surgery." He said, "We're here to free up this bowel and
Mhm.
get the contents out of the hernia. But we're really not here to that's not our primary reason for coming to surgery today is the hernia alone. It's because of the strangulation of
Right.
the bowel." And that's an interesting way to, of course, look at it, and it's the truth, where
Mhm.
we're not gonna bring somebody in after hours, but all hours of the night or on weekends, etcetera, to fix a hernia unless it's this surgical emergency, which you just mentioned. And
Exactly.
I kind of want to just drive that home to our listeners too. So when you find out you're coming in the middle of the night or whatever
Mhm.
on a weekend or whenever it might be to for a ventral hernia repair,
Mhm.
don't before you roll your eyes and think, why am I coming in for just it's a hernia? Well, that's not the reason you're coming in. Coming in to alleviate and hopefully prevent and save some bowel, so you're not having to do a colon resection or a bowel resection. And in
Exactly.
fact, we did have when he finally got it freed up, and I was having to do a lot of pressing from the
Mhm.
external. I was having to do a lot of pushing and reducing for
Mhm.
him while he was working. And you need to be prepared as the first assistant to do that. You need to know, and in a robotic case, communication is key, and telling them where you are on the abdomen and you're seeing. But once we were able to get that out and get see really look at the small bowel, we did see that there was some integrity loss. I mean, it was a little bruised looking, but thankfully it woke back up and pinked back up
Mhm.
during the case. And so he did end up closing that primarily. And I don't want to jump ahead because we are going to
Mhm.
talk about that in just a minute. But 100% that hernia is gonna return. I mean, it
Mhm.
is just with that intra-abdominal pressure, like you said, and that we have in obesity, it's going to the tension,
Mhm.
it's going to recur. It's just a matter of when is it going to recur. So that was just an interesting case, and one of the more
Mhm.
severe hernias that I've seen on the ventral wall for sure.
Right, but that was a perfect point because you illustrated exactly what we're talking about and why we're here. Because when you get an incarcerated hernia, you get an increase in the size of the hernia, but then it can progress, like we said just a minute ago, to a strangulated hernia, which it didn't sound
Mhm.
like he was there yet, but he sounded like he had all those bowel obstructive signs.
Mhm.
He had symptoms of a bowel obstruction, which was the increased
And
nausea, and sometimes
right.
they can be unstable. You can get fever, sudden severe pain. Like I said,
Mhm.
color of the skin change over the hernia site, but you headed off that problem, and that guy was a nightmare patient, and I think I know the physician you're speaking of, and
Mhm.
that is not the patient that you want to be doing at that time with very little resources at that
Right.
moment. That guy needs
Right.
an elective hernia repair with a
Correct.
much bigger thing that we're gonna talk about later on down the line, but that was the only I skipped over, but I did wanna bring up something about umbilical hernias and ventral hernias because they always confuse me. Sometimes it would be booked as a ventral hernia, and they're near the umbilicus, and I'm like, "Well, isn't that an
Mhm.
umbilical hernia?" But
Mhm.
umbilical hernias occur between 3 centimeters below the umbilicus and 3 centimeters above the umbilicus. So that
That's a
area
great yeah,
is an umbilical hernia. Outside of that, it's a ventral hernia. Or if
that's a
it's like
great
you had
point.
an incisional hernia, then that occurs at a site of a previous incision. Maybe they had a
Mhm.
kidney surgery, previous laparotomy. We see that a lot.
Mm.
And I mean, that's those patients like you described are a nightmare patient because they're metabolically sick, their tissue isn't
Mhm.
good. And that's why when we talk about, especially we talked about it with the Bassini repair in the inguinal hernias, you want a tension-free repair because if it's
Mhm.
under tension, it's gonna eventually fail. So, if you can get those edges together,
Yeah.
but,
So so moving on, let's talk about the types of repair that we're looking at for the umbilical and ventral/incisional hernias. The types of repair are the most simple repair is to me
mhm,
is the umbilical hernia that you just it's small, do an open repair. They open it, they close it directly. That's a primary or direct closure. They're going to close that defect with definitely a non-absorbable. Many surgeons still use use Ethibond for
mhm,
those repairs. And these are for our smaller hernias in
mhm,
the umbilical region. They'll still do open repairs, and those are the most
mhm,
straightforward ones. The smaller defects can be closed appropriately with the non-absorbable suture. And so those are just the most
mhm,
direct. I mean, your patient's going to be supine, arms out, small incision typically. A good
mhm,
retraction and exposure from the first assistant is going to allow him to or her to close that defect and be done,
mhm.
right?
And that's when I think it's important to always keep an eye on the surgical field and be looking below where the surgeon is working because you don't want a piece of bowel to come sneaking in there and doesn't see it because it can
Mhm.
happen. And when we're talking about umbilical hernia repairs, there's a couple of different types, but I had some today. I did a inguinal hernia repair, then I did an umbilical hernia repair, but I'll talk about that in a minute. But go ahead. I didn't mean to interrupt. Go ahead.
Oh, no, that's okay.
Mhm.
I wanted you to toss that in. I'm so glad you
Oh,
mentioned
sure.
that because we think, "Oh, this is simple, this is straightforward," but
Hmm.
exactly, our eyes are the second set of eyes, and we're looking
Hmm.
under every time his needle goes through that fascia, we look, we wanna make
Hmm.
sure that underneath they're free and that they're not snagging anything and really just serving as the second set of eyes for the
Hmm.
surgeon when they're throwing those stitches in there. But once those are closed effectively, and we then close depending on the thickness, the layer of the abdominal wall, what the sub-Q fat layer is, it may be one or two layers of closure on our end. I might close the sub-Q, close down some dead space. You
So glad
mentioned
you brought that
something
up.
about talking about closing that what a lot of times what the surgeon will do, or
Hmm.
I've done it before also, is
Hmm.
tacking the the belly button back down from the skin, the
Exactly. Yep.
underside of that subdermal or deep dermal skin, tacking
Hmm.
it back down to the fascia to make that belly button. If it was an outie, it can be an
Hmm.
innie. Again, just kind of taking care of that.
That's true. Yeah, and a lot of times you'll see that in that repair. Like I did one today, I was talking about it, and it was an intraperitoneal onlay mesh repair, which is with the Ventral XT. I mean, we don't promote
Mhm.
any particular products. This is just what we used. So it's got
Mhm.
that bioabsorbable coating on it that prevents the bowel from adhering to it because it's on the inside of the peritoneum. So therefore, nothing can come back through the defect again, even though we're closing the defect with it. It's a circular piece of mesh. They come in all different sizes. It's got two long tails on it, and then that's the technique. You put it down in there with a forceps. Well, you develop the plane first after you reduce the hernia open up the hernia sac, you dissect about 3 to 5 centimeters circumferentially around it, and that's where I
Mhm.
wanted to add what you just talked about. And, like, a lot of times after the surgeon does that, you'll see him feel around with his finger to make sure there's no adhesions, no bowel stuck up
Mhm.
there at all, and then we'll move to the repair. And usually he's gonna turn around and ask for the mesh, and he'll reach for it. When he does that, that's when I stick my finger in there, and I do that too, just
Mhm.
as a second set of eyes, a second check. Not saying that I think, "Oh, this guy doesn't know what he's doing, he didn't." It's just another pair of it couldn't hurt. I mean, because 'cause
Mhm.
I've missed things, surgeons have missed things, I've called things to surgeons'
Mhm.
attention that they didn't see, so that's what we're there for, to prevent
Right.
any problems, help the surgeon make it go faster. So, you take that
Right.
little ring, you pop it inside, you pull it up, and then you take the non-absorbable sutures you were talking about, and you go from the one leaflet of the defect through that long strip on the ventral X, through the little ring inside it, and then all across the other side, and the same thing on the other side, the leaflet, and then the ring on the other side. And then
Mhm.
we typically don't tie those down till the end. So they'll place all the sutures. So, and like you said, it's a non-absorbable suture. So what I've seen
Mhm.
used in the past is what you talked about, Ethibond. I've seen Proline used, and I've seen Neurolon used. It's between nylon and Neurolon is nylon is a monofilament, Neurolon is a braided multi-fiber filament. So it's a
Okay.
multi-filament, it's not single. So a lot of times what they'll do is they'll put the stitch through, and a lot of times they'll cut it, put a hemostat on it, and then lay it down, and we'll do that. If you have a lot of those for a big defect, one thing I learned is to take an Army Navy, clamp it to the drape, and then each ring of the hemostat you put on the longest blade of the Army Navy, so they stack one on top of the other. Because I'm sure you've seen this too. They'll get all tangled. You want to tie them in order, and now the first one is now the last one, and you're trying to untangle all these hemostats because you got these sutures. So I
Mhm.
found that to be helpful in that. So
And
you went over.
What
Mhm.
John is talking about there is when they do an open repair and they do use mesh. And so we're not
Mhm.
intra-abdominal, we're not laparoscopic, we're not robotic. So if you've never seen that, hopefully you will get to do that. So this is not
Mhm.
what John's talking about is not a primary repair. A primary repair is what I described as just closing the defect with suture and then getting out.
Mhm. It's a tissue
John
only
is talking
repair.
about a mesh repair, an open repair with mesh is essentially what he's
Mhm.
talking about. So, and the technique that he's talking about is how you put it in, then pull it up, oppose it to the abdominal wall, and then sutures are placed
Mhm.
and statted with hemostats and in the fashion that he was. And hopefully you know what he's talking about and you've done. I haven't done a lot of those, but I have done those some with surgeons and it's an interesting repair, but
Mhm.
that's important to know when you're going into these. It might be booked or boarded as a open umbilical repair. Well, you need to know as the first assistant, are we doing a mesh
Mhm.
repair or is it going to be just a direct tissue only repair? So those are things that you need to ask for
Mhm.
sure.
That's
Because
a
don't
great point.
assume that just because it's an open umbilical hernia repair, don't assume it's just going to be that means it's going to be a primary repair. We still
Mhm.
might be using mesh, and then in that case, you need to know,
Right.
what suture material you need, and he or she uses, and etc. What mesh, etc. And so just knowing as much as you can about the case
Mhm.
and what the surgeon's doing is important. Many of these, I feel
Mhm.
like most of these I shouldn't say most, but many of these types of hernias are repaired these days through the laparoscopic or robotic assisted laparoscopic approach.
True. That is true. And what
So,
you said, well, I just wanna go back to that for a second because it's so important. That is where the first assistant adds value to the case because those preference sheets aren't always correct. It may not be booked correctly. So that's where you, as the first assistant, if you're doing multiple cases with that surgeon, as the ones ending before your umbilical hernia, you can say, "Hey, doc, are we using mesh on the next case?"
mm,
Because Kelly
right.
highlighted it. You have the tension-free tissue only repair, or then you have the intraperitoneal onlay mesh, and then you have the extraperitoneal onlay mesh.
Mhm,
So different techniques, but a lot of times you'll see them with the umbilical hernia. They'll start with a semicircular infra-umbilical incision. It'll right at the bottom of the umbilicus. They'll make like a semicircle, like a smile, and then you'll
mhm,
develop that down till you get to the fascia. But what you'll see a lot of them do, well, they take a hemostat and they'll go around the umbilical stalk. They want to free that. So that's where you come in a lot of times as the surgical first assistant because they will separate that tissue with the hemostat, open the jaws, and then you'll take the bovie and you'll bovie through that tissue. So they'll
mhm,
present it to you, and then you never want to go past the point of the clamp, and you want to watch the tissue on all sides to make sure you're not hitting anything you're supposed to. But so they'll take the hemostat and snake it around the umbilicus, and then eventually they'll detach the stalk from the abdominal fascia, and then that's when you'll repair the defect and all that, and then we'll talk about
Right.
a special dressing technique at the end for that. But so that's a dead giveaway that you're doing an umbilical hernia.
Right.
They start
Right.
going around the umbilical stalk, but,
And
um
I also wanna mention here, John, that we're being very
mhm,
intentional about not going into properties of mesh, types of mesh, even,
right,
even how to handle mesh, because we do in the very, very near future want to do an episode and are going to do an episode on everything about mesh you can
yeah,
imagine. Like, we're going to really dive deep,
so many
and that's
types.
gonna be a really good, informative, and educational for all of us, for, you and I researching it and for the
Mhm,
listener about mesh. And so we're gonna talk about some of the applications of all the different types of mesh. So we're going to probably
mhm,
circle back into some of this that we're talking about now. But we wanted to lay the foundation and talk about hernias and get this hernia series done as well. So we're not going to be going too deep at all into the meshes. And I just wanted to put that out there because in case somebody's listening and wondering, well, why aren't you talking about the mesh and what type of mesh you use when, is that's why, because we're going to do a
mhm,
whole mesh episode. So, um,
exactly.
yeah, moving on. So let's go ahead and talk about that dressing technique. I mean,
Sure,
I want to do it because on
yeah,
this particular, we're talking about these umbilical. This is the really umbilical hernia is where you're really going to use
yep,
this dressing
and
technique. In addition to, I want to mention an abdominal binder on any of these ventral wall
it is kind of surgeon specific because
hernias. It is.
I did it today and he did not use one,
It
so
is.
I
It
asked
is
and they're like, "I
surgeon.
don't use one," so
Yeah,
but
yeah, yeah. And that is surgeon specific, but something for the first assistant to keep in mind. That's
mhm,
something I think from a patient standpoint, it just feels good to have that
I think so
pressure,
too.
that pressure on your belly. But yeah, definitely, yeah,
Mhm,
obviously, if the surgeon says, "No, I don't like
yep,
them, don't want them," of course, you're not gonna put one on there, but just something to consider and keep
so,
in
yep,
your mind,
I asked
on
them,
these.
and if he
Make
says
sure they're in the
no,
room.
I'm not gonna be like, "Are
Okay.
you sure?" If I were you, I
Okay.
would do it, but no. So, like I said, when they dissect around the umbilical stalk and they free it from the abdominal wall, a lot of times what you'll see them do is stick their finger inside it and look at it to make sure they didn't buttonhole it and go through the skin because then
Mhm.
now that's a nidus for infection. They're going to want to close that if they see that. So, and that's when you tack it down. And like Kelly said, you close it in layers up to the skin because nature abhors a vacuum. You want to close down the dead space, but they are going to develop a seroma no matter how well you close that. And that's what this little special technique is for. I think I first learned it working in Michigan is where I picked it up, but I've seen it in other places as well. So a lot of times what I'll do for the umbilicus is I'll close the skin in whatever fashion they like, whether it's with Dermabond, Prineo, or Steri-Strips and Mastisol. And then I'll take either a 4x4 or a cotton ball, whatever they like, whatever the surgeon likes for dressing. This guy today liked cotton balls. So I'll put cotton balls down inside there to fill up the belly button so it's even with the skin, the height of the skin. And then I'll put a Tegaderm over top of that, and then I'll take the local syringe, usually left over on the field, that's got a 10 cc syringe typically and a 25 gauge needle. And then you typically use the what I call the, and I think you do too, the Pop Tart size of the Tegaderm or Opsite. You want to set that over it so the dressing is in the center. And then I'll come from outside the dressing through the skin, and I want to go through into the either the gauze of the dressing or the cotton ball that's in there. And then I'll draw back on the syringe and I'll actually draw the air out of it. I call it a vacuum pack dressing because you'll see that
Mhm.
collapse down. And I'll do that a couple of times depending on how big it is, how much dressing is in there or whatever. But you want to make sure that I typically don't go through the dressing, but you're going through the skin. So that's going to provide that seal so it doesn't deflate again. But basically you're just creating a little vacuum, and what you're is creating a splint really because that dressing will get really hard. You'll feel it get very hard in there. And what that does basically is it'll force down the tissue back into its original position and help prevent them from getting a big seroma. I can't keep my thoughts ordered tonight. I'm sorry. I'm just exhausted. I had a long day today. I got up early and I was running around. So it's hard to keep my thoughts organized. So you'll stick it in there through the skin into the dressing and draw back on your
Mhm.
syringe. Typically I'll do that 2 or 3 times because I want to get that as hard as possible and as deflated as possible. And if I
Right,
have
and
to
it's
go
so
through
satisfying to see it suck down and be,
oh, it
get
is.
real vacuumed down, and you've got that good pressure on it, and
It
so,
is.
yeah,
Especially if you can use a bigger syringe than a 10 cc, like a 20, you can do it all at once,
yeah,
but
right.
and sometimes if I have to go through the Tegaderm itself, I'll put a second Tegaderm on top of it. but
Mhm.
I'll look and see if I can find a video and insert it in here, if not pictures or something on a technique to do that, but I always call it a vacuum pack dressing. I mean,
That's
I
what
don't
I
know
tell
what
yeah, that's what
yeah,
I call it, vacuum
and
dressing,
I've
yeah,
suggested
so
it, surgeons have started doing it, I'm like, "Do you want me to" they're like, "What? I've never heard of that." And then sometimes I
I
just
can't
do it.
believe there's people that have never heard of it. I just thought it was a technique that's been around forever. I mean,
It has
I've
been,
heard
but
it
not every
from
region of the country uses it. I've
yeah,
been
that's
places that don't.
interesting.
So,
Anyway,
but I think
it's a
it's
great
important. Yeah,
and
it's
it's so
important to
cool
do
and so
that.
simple. Yeah, that you're sucking that you're putting pressure on that particular
Mhm.
tissue, right, where they would be apt to form a seroma. So, yeah, that's a good thing. And I'm sure there's a YouTube video on it or something. So if you,
Yeah, I'll have to look for
you know,
that.
are watching and you don't know what we're talking about, just try and Google it. It's a
Mhm.
space bag. I've heard it called a space bag,
Oh, space okay.
a
Yeah, I guess because
space
those vacuum
space
that you
bag or
vacuum those
something like it.
down.
Yeah,
You can find
space bag
a
dressing or
video. I'll put a link to it or I'll insert it in here if it's not too long, or pictures if I can't do that, but let me just quickly look over
mhm,
my notes to make sure I'm not missing anything. Nope. And if I didn't mention it earlier, I know that I said that umbilical hernias occur 3 times more likely in women than men, and the reasons for that are because of pregnancy, premature
mhm,
birth, or increased abdominal pressure, which happens during birth,
right,
and, obesity is another reason, but that's not exclusive to women, so,
right,
um, but yep. So, yeah, you have the asymptomatic
right.
and then the incarcerated and strangulated as we talked about, and I think that's about it. That's all I have.
Mhm.
If there's
So
something
the
that we missed, let
yeah,
us know.
so the other well, yeah, just the other approach. I mean, the other approach would be laparoscopic
Yeah.
or robot assisted, you
Yes.
know, doing that approach. So if you're going to do that approach, and like I mentioned earlier, we know that the patient's going to be supine, arms tucked typically. Some places don't tuck arms for robot. Like they think the robot can come in and the arm can be out and it's not going to be any, that's fine. I know I'm more used to just tucking both arms with the robotic approach. Again, we do want to make sure that, especially if the on these umbilical and incisional or ventral hernias, they're more towards the midline of the abdominal wall, and those are the particular hernias we're talking about in this episode. You do want
Mhm.
to make sure that that patient is flexed over the or positioned over the flex joint in the bed. And so I usually line up the top of the anterior superior iliac spine,
Mhm.
or you can just eyeball where their belly button is and kind of get them over that
Mhm.
flex joint. You can have anesthesia go ahead and flex the bed slightly and see
Mhm.
if they're going to flex down just so that their legs are down a little bit. It create what this does is
Mhm.
create more space in the abdominal cavity for the surgeon to work when they're doing this robotically or laparoscopically.
That's a great point.
So on the robotic on the robotic approach, you do wanna consider also that you will likely be using, or it's a good idea to use, the longer trocar, the long trocar
Mhm.
at the distal site. So typically, the surgeon's gonna line whatever side of the room your robot is coming in on, whatever side of the patient the robot is coming in on, typically, the trocars are gonna be lined up. It's usually only a 3-arm surgery for these when you're using a robot, and they're going to be lined up on one side. Where I'm at currently, it's the left side of the patient. I think the patient's left
Mhm.
is where we place and so the arms of the robot are working up in an up direction. So that's where
Mhm.
that flex comes in handy. So you're flexing, it creates a little more space. It keeps the robot arms, that longer trocar being down distal where the patient's thigh is going to be. It keeps that robot arm from hitting and being hindered in any way. So just some considerations there for that robotic
Mm.
approach for these. Again, most of the time, these are going to involve a mesh repair. You can again ask your surgeon what that's going to involve. I haven't worked with any surgeons recently, John, that have done just straight laparoscopic repair of these. I know that there are surgeons that still
Mhm.
do laparoscopic
Right.
only repair of these. I have done so I don't but I can't remember if we really flexed, if the flexing was necessary in laparoscopic only approach. In other words, non-robotic approach. I feel
Mhm.
like that came into play with the robot. So I don't know
Yeah.
if you have any thoughts towards that.
Typically, the incisional hernia repairs I've done have either been open or robotic. I haven't really done
Mhm,
any laparoscopic ones. Now, another point you brought up, I thought about a caveat when it comes to robotic hernia repairs for these. Be prepared to also to sometimes you'll have to move your trocar in or out for the surgeon. Most
Mhm.
likely you have to move it out because of that working distance when they're coming in. They're
Mhm.
working midline and they come in from the side. So a lot of times there's not a lot of room for them to work. So you'll have to clutch that trocar further out so they get more distance to where they can operate with their wrists. And another
Mhm.
caveat to that, when it comes to positioning, again, it depends on how they orient their trocars. I've worked with surgeons that put 3 trocars in a line as far lateral as they can get on one side. What also
Mhm.
helps with that too is if you bump the patient up and you put a rolled blanket underneath them, because that way it allows the robot arms to articulate further over because they're slightly at an angle now, so these arms can get further down this way so they can work up at an angle under the
Oh, I've
abdominal
never
wall.
done that. That's interesting too.
I've
Yeah.
suggested it to those surgeons, specifically
Okay.
the one that you're talking about. I've suggested it
Mhm.
to him and he's like, "Nope, that's okay." So,
Right.
some are
Right.
familiar with it, but trust me, it does really help. It does really
Mhm.
help. It
Yeah,
gives you a little
that's a
more
good
room,
point. Yeah,
gives
that's
you
a good
more
tip.
articulating room, and they're allowed to get,
Do you put the
it
bump at
allows
their
them.
hip or under their
I put a blanket between
torso?
their ASIS and, like, their rib cage, so it goes under and it bumps them instead of being supine and flat. Let me do this. Supine and flat, they're like this. So they're almost like a little, I don't know, lazy
Yeah, they're
lateral
like at
maybe,
an uh-huh,
but it's
yeah,
the
okay,
bump would be right here bumping them
I
up so
see.
your arms can come down this way so they get a better shot at the abdominal wall.
Okay, yep, that makes
They
sense.
don't
So
have to
you're
flex
putting
their wrists so much when they're using the robot, but, not
mhm.
everybody does that, but keep it in mind. It might be a suggestion you wanna suggest.
Yep, yeah,
A
for sure.
suggestion you wanna suggest. Yeah, that's
Sugge
correct.
a tip you wanna
Might be a
suggest.
just a suggestion, it's
Oh,
redundancy.
free advice.
Yeah, a redundant
No,
redundancy.
I have never done that and never worked with a surgeon that did that, but that is a good tip,
Mhm,
and even with that long trocar in place and
mhm,
pulling it out, sometimes it still is a challenge with it's hitting something or it's still a challenge for them.
yep,
So that's a great yeah, that's
yep,
a great nugget of information there.
and you wanna be
Uh,
careful when you do that you don't pull it completely out either, and then
mm,
if you do, then
mhm,
you have to deal with that,
yeah,
undock it, re-put it in there,
yeah,
but
and that
but I
takes time.
think this is another point I wanted to bring up, and it goes to trying to constantly improve as a professional. Like that point I just gave you, if you watch videos, and I tend to do that a lot, maybe I'm just a nerd on that stuff, but if I'm doing a surgery, I'll research it and I'll watch other videos of how other people do them, but I'm watching everything. I'm watching how they position the room, how they position the patient, what positioning aids they do, and you can learn a wealth of knowledge from how
So
other people
much.
do it in other, not
Yes, so
actually
much.
having to go travel to another place, but by watching people or listening to like sages or other
Mhm.
videos of people how they do their surgeries, you pick up little clinical pearls that
And
way,
it's like a light bulb
you
goes
know?
off and you're like, "I never
Mhm.
thought of that." And you might be
Yeah.
thinking, "Well, I'm tooling along and, the old saying, if it's not broke, don't fix it." But what if I can do it better? What if we can
Mhm.
do it what if we can make
Yep.
it better and improve something?
Yep.
I mean, it's such a bad state of mind to be in, like, "Well, there's nothing wrong with the way I do it. I've been doing it like this forever. I don't wanna
Mhm.
change it." I'm not like that. I want to learn new and better ways, and,
Oh, I
um,
agree. Yep.
so and like you said, I think we should all be like that.
Yep.
Always look for be ready to learn from other people and other situations and with technology the way it is and social media the way it is, there's no reason we've got resources at our fingertips that let us we can see how they do
Mhm.
it and across the world,
Yep.
how
True.
they do things. So yeah, it's a good advice.
Yeah. I picked up something from somebody at an assignment was on I was on. I asked him, "Where'd you get that?" He goes, "I don't know. I was watching a video on it last night and they did it, so I thought I'd try it." Out
Mhm.
really cool. So,
Mhm.
anyways.
So on these, another thing I want to mention for these robotic repairs, again, typically we're going to be using mesh on these repairs. So
Mhm.
just keep in mind as the first assistant, your surgeon's going to be closing the defect and fixating the mesh to the abdominal wall. So if you've
Mhm.
never worked with this surgeon, if you're not familiar, you want to know it's going to be two different types of suture. We're going to use an absorbable and a non-absorbable
Mhm.
in these cases, and just have a chance to chat with your surgeon about their technique. What do they do?
Mhm.
What do they want? What kind of suture do they want? Length of suture is a big deal when they're going around the circumference of the mesh after they oppose it to the wall. The length that they want to work with. They another consideration is, do they want the suture cut needle driver or not?
Mhm.
I work with surgeons these days that they're selective in their suture cut needle driver usage, and typically in these ventral wall hernias, when they're having to run that suture around the periphery of the mesh, tacking it to the abdominal wall. They just want the mega needle driver. They don't want the suture cut because their
Yeah.
rationale is if they make a mistake and cut it, they've got to take all that out and start all over again. It's
Hmm.
just a big pain. So they'd rather not deal with that, and they just want the mega suture cut. Um, I'm sorry, they just want the mega needle driver.
Right.
So, and you'll either pass the suture, the robotic scissor to them to cut, or if you happen to have an assist port, you can reach in and cut it for them. Typically, we
Hmm.
don't have an assist port on these, and they'll just take the scissors back real
Hmm.
quick and cut it themselves. So that's another thing. So just really know what type of mesh your surgeon wants. We're going to talk about I don't know, or we could say it now, how far typically what our surgeons are looking at for how big the mesh needs to be as it's related to the size of the hernia. A lot of times they can measure, they'll
Hmm.
sometimes they'll use the robotic instrument and
Hmm.
open it. They know that's, I don't know, what is it, 2 centimeters or something if they
Depending on
open.
the instrument, some are 3, some are
Depends on
2.
like if
Yeah.
it's yeah. And you'll see them if you see them holding that instrument up to the
Hmm.
defect, they could be measuring it, eyeball measuring it that way. Sometimes I will cut the ruler in half and pass
Hmm.
the centimeter side into the abdominal cavity.
Yep.
I'll use a grasper, pass it into the cavity. They grab it, they hold it up, measure the defect, and then we know what size mesh. Many of the meshes here used on this abdominal wall are going to be round or oval in shape. I will say that. And then that mesh is going to extend. And this is something for the surgeons to know, but also something for us to know is it's going to extend a certain uh, length. It's going to a certain, what am I trying to say? Diameter overlap. Yeah, overlap on coverage. Like it's going to be bigger than the hernia. You're not ever going to use a mesh that's exactly the size of the hernia. That would be futile. And I can't, and I'm talking about this, and I can't remember I can't remember what the measurements are that the mesh that overlap is. Do you remember what the exact measurements are in centimeters? And I read it recently, y'all. I didn't just read it, I heard it. I heard somebody say it, and it was very a particular minimum overlap. So, it's in
Hmm.
centimeters. If it's a couple of centimeters, 3 centimeters, 5 centimeters, something
Yeah.
like that, the mesh is going to extend beyond the diameter of the actual defect.
Right. Exactly. So yeah, that's yeah. I think we've kind of gotten more into robotic hernia repairs, but that's just another type of hernia repair for those incisional ones, or since sometimes they will repair a diastasis along with that. But I think that's getting into another. We've talked about. We didn't talk about it. We mentioned it. You have hernias, and then you have a diastasis recti, which is actually not a hernia. It's a weakening of
Right.
the abdominal wall. You can see a bulge like you can with a hernia, but it's not. It's more of a pooching
Not
out
an actual
of
hernia.
the
Right.
right. Exactly. So,
Right.
but I guess I do have a clinical pearl for you people that do, or for us that do a lot of robotic hernia repairs, and you have to roll up the mesh and get it down the trocar into the abdominal cavity to give to the doctor. Those things can be kind of tight depending on what size trocar you use. And some docs will use a 12 trocar to make it easier. But if it's a really tight thing, you can roll it as tight as you can get it, and it's still really tight. So what I found helps is if you use a Clarify, is to take that Clarify port cleaner and dip it in the flux or the honey or whatever you guys call that they put on the bipolar forceps and stuff and that go in there. And then you just pass that, you swipe that down the trocar, and then that'll lubricate the trocar, and it has no effect on the mesh itself. So you can just help slide the mesh right in through the trocar. So
Okay. So you're talking about I call it the plunger. You're talking about the big thing that looks like a
yeah,
Q-tip that
yeah,
comes
the
with
Q-tip, the
the
port cleaner. Yeah, I mean, there's
cleaner.
another name for it that I won't mention here,
But you
but
dip it
in that
you wet it?
I put it in the flux, that little honey stuff that they put on the end of the bipolar forceps
Oh,
to
the
keep
lube,
the
like
well,
Electrolube.
Electrolube, yeah, I couldn't think of the
Oh,
name. Thank you.
okay.
Yep. I
Okay,
coat
no,
it
I've
with the
never heard of
Electrolube,
the
and
tip.
then I pass it down the inside of the trocar, and that coats the inside of the trocar, and it makes it, because you'll wet the mesh anyways to put it in, and when those two
And it
meet, it'll just slip right in if you're
and
having
that
a
has
hard
no
time
effect
getting
on
it
the
in.
integrity of the mesh.
Nope, doesn't. I've
That's a good
checked.
tip. I've never
Mhm.
done that, John. I've never heard of it
Mhm.
and wouldn't have thought of it because I'm usually paranoid about the integrity of the mesh and doing something to ruin it. But, that's
Which,
a good tip.
yes, I'm
Mhm.
gonna plug, that's why it's important. If you can get your rep to set you up with a first assistant course at Da Vinci, that's
Mm,
a reason you pick up those
yeah,
pearls from places
that's
like that.
right. That's true. That is very true. Well, good. So, yeah, so I think have
Mhm.
we covered everything?
I
We
think
talked about
so.
anatomical layers that we're
Mhm.
dealing with. Not any real critical structures in the abdominal wall up in this area. I mean,
Just
there's
you wanna make sure bleeding is
little
hemostasis is
vessels,
on point for this.
but no major vessels, no major nerves right here in this area
Mhm. True.
that we're
Not
worried
like
about.
inguinal,
So,
right.
all right. So, yeah.
Yeah.
So, we've talked about indications for repair, risk for recurrence. Recurrence is always a big deal to the surgeons. They do not want the hernias to recur. Their
Right.
hernias are famous for recurring, and the same risk factors that are risk factors of developing hernias are the same
Mhm.
risk factors that exist for recurrence of the hernia. We really want to avoid wound infection, guys. We really, really want to avoid wound infection. And I do agree that the IOBAN over those open repairs is helpful. And talking about that, talking about recurrence, John, we do want to just mention
Mhm.
real quick that when a recurrent hernia, if it is a recurrent
Mhm.
hernia that's presenting to us and is our case for the day, whatever repair the surgeon, whatever technique or approach the surgeon has chosen, it's because it's the opposite. So if somebody's had
Well,
a robotic repair before of this hernia and it's recurring, we're likely going to move to an open repair
mhm.
this time and vice
Right.
versa. So
Yep.
if they've had an open repair before and it's a recurrent hernia, then
Mhm.
they're going to choose another approach and not do the same approach because I think it's just counterproductive and even more likely to recur again. So that's a big deal for our surgeons. I like to know what our surgeons are worried about and what their concerns are and what their considerations are for these cases. And wound infection is a big one because of the recurrence rate of hernias. And we want to do everything we can and help our surgeons give the most excellent repair
Mhm.
that they can for our patients.
I agree. And it's kind of like I said, I'm a little muddled tonight, but then it's hard to separate all these hernias out into individual ones. So there is some overlap with other hernias, but we'll do
Mhm.
further more episodes with other hernia repairs. Plus, we will also do a wrap up episode that kind of brings it all together. So it might be a little longer of an episode. So Michael,
Right. And
forgive us for that. But
yeah, and just some insight, our next hernia
Mhm.
series, and it may be maybe we can do it all in one, just it'll be a 3 episode series. But our next
Mhm.
hernia series, we are gonna be talking about some of the more rare abdominal wall hernias and complicated, complex, such as the component separations
Oh,
and
right. A
the
Reeve Stopa. Yep.
the very large, complex, recurrent hernias. They're
Those
high
are going to need an
tension,
episode
very
in and of
large.
itself.
Yeah.
Yep.
So, but we really wanna give the information to our listeners. It's very
Exactly. Yep.
it's good information. It's interesting to
Mhm.
learn about and knowing what our surgeons face when they're presented with these patients and these complicated hernias.
Yeah.
So that's what
And
we're gonna be talking about on the next one, yeah.
yeah, and that's a great point because it is a big, complicated operation.
Mm.
Prepared you are, the better the operation is going to go, the happier the surgeon will be, and the better the outcome for the patient. So,
Yep,
um,
yep.
yeah.
So,
So,
as usual,
anyways,
guys, we appreciate you listening, and we're in the heading towards the middle of April right now when we're recording this, and I've got
mhm,
conference coming up next week. John's
that's
unfortunately not gonna
right.
be able to be there this year. Um,
No,
I've forgiven him for it, and he's gonna go to the you're gonna go to
and
again
I'm
to
going to
the
be at the
Maddox
Maddox Trauma
the
Conference. I'm
Maddox
so
conference,
excited.
which
I'm
is
gonna see if I can.
a big expense and a big time commitment for you. It's
Mhm,
a longer conference, and John's
yes.
passionate about trauma, and he just learns so
Mhm.
much at that conference, and will be able to bring us some good information to the podcast too, I'm sure.
Yeah, it definitely. I mean, for
So,
me, it was eye opening. These are the people that are make make the policies for treatment of trauma patients. All the
yeah,
big names are there. I'm looking
so
forward to it. There's a
interesting.
couple of guys like I worked overseas as a medic. So Frank Butler, who is one of the founders and creators of the TCCC or the Trauma Combat Casualty Care, he's speaking this year there. So I'm excited to meet him. I'll probably get his autograph. I'm such a fanboy.
Uh,
But Patrick Georgioff is usually there. He's the one that started the Behind the Knife podcast. Dr.
mm,
Maddox, of course. I want to see if maybe I can interview him because he has some great insights. He talked about the Lady Diana accident and how she actually died and the injuries she
mhm,
sustained. He spoke to the surgeon about that. But
um,
there's just so much stuff, and it's Sunday through Wednesday. I love it. It is a little
yeah,
more expensive than our conference, and unfortunately, I couldn't do both this year because I'm on a travel assignment. I can only get so much time off,
yeah,
and it would have been a big expense to attend both. But I have done that in the
yeah,
past, but I just can't this year. So, but I will miss not being there. But yeah, April
right. Well,
17th and 18th, correct?
yep. And
Or
I'll
is it
take good notes. I'm gonna take good notes and hopefully, yeah, bring back
Mhm.
some information, and I'll do a quick recap
Oh,
as
that'd
well
be
on our
great. I wish I
conference.
could be
So,
there to do that with you, but I
yeah.
think it's 16, 17, and 18 because only because I think Thursday they're gonna do another Da Vinci workshop, if I'm not mistaken. I'll have to
I think there's a Da Vinci workshop in the area that coincides with the
Oh,
conference,
okay, that's
and
what it
that's
was.
what
Gotcha,
they
thank
kinda
you.
put the word out about that, but it is the 17th and 18th, yeah, in Atlanta.
Perfect.
So, yeah, so I'm looking forward to that, and we will circle back and get everybody filled in. If you weren't able to go, we'll get
Mhm.
people filled in, and you can bring us back some nuggets from your conference as well.
They definitely will. Yeah, we'll have a 2 conference wrap-up episode,
Yeah.
but if anybody's flying into Atlanta and you need to rent a car, do not use Hertz in Atlanta Airport. I used to live there, and they never have cars for you. Doesn't
Oh,
matter, you
god.
could reserve it 2 years in advance, and they'll never have a car for you, so
Oh
Hertz
gosh.
sucks, so don't use
Yeah.
Hertz. That's my
Okay.
personal opinion.
That's a opposite of a plug. That's a anti-plug.
Yes,
That's a warning. Don't
it
use that
is.
company.
Yes, I've been screwed many times by them, so but
Mm.
it's a great experience flying into Atlanta, and renting a car is super easy. Just don't use Hertz.
Okay. All right, everybody. We will see you next
All right, you
time.
guys take care, and anything you need, let us know if there's something you want us to cover, or I'm starting to go off on a
Yeah.
tangent again. So,
We're
but
always
thank you. Don't forget to like, comment, and subscribe. And if you don't mind, you want to do us a favor and go to Apple Podcasts and leave us a review. That'll help us get out to more people. So, thank you very much
yeah.
because I think we got some special guests coming up pretty soon that I think you guys will be
Yeah,
excited
we've got
from.
some
So,
good stuff. Yeah, we got some good
mhm.
stuff coming.
All right, Kelly, great seeing you
All right.
again.
Yeah, you too.
Take care. Thank you for joining us today. We invite you to like, comment, and subscribe to our podcast. Feel free to look us up on Facebook at The Surgical Assistant Podcast. If you like, you can also email us at thesurgicalassistantpodcast@gmail.com. We look forward to seeing you on the next episode. Content of this podcast is created for surgical assistants and is educational only. It is not intended to diagnose, treat, or offer medical advice on surgical conditions.